On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
Thank you very much, Elliot. As always, a pleasure. We've known each other since 1978, just as an irrelevant detail. I'm actually honored to be able to present the results of the trial to assess chelation therapy on behalf of my co-investigators and co-authors. I will run through the slides quite quickly, and afterwards I presume that there will be opportunity for us to interact.
But I should have mentioned that there's an updated slide file that's available to you electronically, and these are the ones that Dr. Lamas is going to actually be showing. You have a copy of a set that was submitted just before that one.
And if you can mention the embargo.
I will.
The background of chelation therapy, I think, is fairly well known to most people here. EDTA binds divalent cations and permits renal excretion of those divalent cations. In 1956, Clark reported a series of patients with successful treatment of angina. From 1956 to the present, that is 56 years, the use of chelation therapy has increased to over 100,000 patients annually in the US in a 2007 survey. Case reports and case series have been published reporting benefit. Small clinical trials tended to be negative for surrogate endpoints. And there is evidence of harm, especially from rapid infusions that may cause hypocalcemia. The TACT timeline begins in 2001, all the way on the left, when an RFA, again a peer-reviewed RFA that went through NHLBI and NCAM Council, was released. We applied, and TACT was funded as a cooperative agreement with NHLBI and NCAM as part of the investigative team. An IND was obtained from the Food and Drug Administration. The first patient was randomized in 2003. The 134th site was activated in 2009. There were 1,708 patients enrolled by 2010, and the last follow-up was about a year ago. The design overview for TACT is as follows. It's really a factorial design. And this factorial design splits the study into 4 cells: chelation or chelation placebo, that is infusions or infusion placebo, and high-dose vitamins versus oral high-dose vitamin placebos, identical placebos. The study was double-blinded, and the study therapy was delivered to the sites by a central pharmacy. There were 40 infusions required of each patient. Each infusion lasted at least 3 hours, 30 weekly, and then another 10, 2 to 8 weeks apart. The reference at the bottom is the design paper. Eligibility. Patients were age 50 or older. They'd had an acute myocardial infarction at least 6 months before, and the creatinine was 2 or less. You can see the other entry criteria. The chelation infusion, if you stay with the top 2 lines, had 3 grams of EDTA adjusted downward based on estimated GFR, and 7 grams of ascorbic acid, again, delivered intravenously. Then there were electrolytes, some B vitamins, local anesthetic, unfractionated heparin, and then sterile water to complete 500 milliliters. The placebo infusion was normal saline and 1.2% dextrose, 500 milliliters. The primary endpoint was death, MI, stroke, coronary revascularization, and hospitalization for angina. The original plan was to randomize 2,372 patients and follow up a minimum of 1 year, 85% power for detecting a 25% difference. In 2009, due to slow enrollment, we asked for a reduction of the total sample size to 1,700, understanding that we would not take a loss in statistical power because of the increased follow-up time, and Because of this, the DSMB approved our request. Treatment comparisons were as randomized, that is intent to treat. There was two-sided statistical testing. The log rank test was used using time to first event. Interim monitoring using alpha spending function with O'Brien-Fleming monitoring boundaries. And because of the length of the study with 11 DSMB reviews to ensure safety, the final level of significance was 0.036. I have a different version of this slide for the presentation this afternoon for those of you who will be there. Let me just point out, I know it doesn't project well. Let me point out the median age is 65. Patients are either obese or overweight on the whole. Over 30% were diabetics. Over 80% had had a prior revascularization. Over 70% were on statins and beta blockers. And over 80% were on aspirin. So patients were on reasonable evidence-based medicine post-myocardial infarction. We delivered a total of 55,222 infusions. 65% of patients completed all 40, 76% completed at least 30. And then there were reasons for discontinuing the infusions. Consent was withdrawn by 17% of patients at some point during the course of the study. 79 patients discontinued infusions due to adverse events or side effects. And you can read this. There were 4 unexpected severe adverse events, possibly or definitely related to study therapy, 2 in the placebo group with 1 death, and 2 in the chelation group, again with 1 death. This is the primary endpoint results. As you can see, there is a significant difference favoring chelation therapy in the primary endpoint of death, MI, stroke, coronary revascularization, or hospitalization for angina. The hazard ratio is 0.82, the confidence intervals are 0.69 to 0.99, and the p-value is 0.035. The components of the primary endpoint, I would like to just take your eye to those components that are non-mortal, or those components that are not death, and look at the hazard ratio. The hazard ratio is very much in line with the primary endpoint. Death, there was no evidence that we were able to reduce total mortality, although the statistical power to do so was low. There were some subgroups that were analyzed, and these were all pre-specified subgroups. What I am giving you here is the P for interaction with treatment group assignment. And it's important to note that time from MI to enrollment, there was no interaction with the treatment group assignment. Whether the site that enrolled the patient was a chelation site or a conventional site, that is a site that practiced conventional cardiology versus one that was already practicing chelation therapy, that did not interact with the treatment assignment. Oral vitamins or placebo, remember it was a factorial design, again, did not interact. MI location did have an interaction with treatment assignment, and diabetes did as well. This curve on the left shows the patients with diabetes, 31%. Again, it's a small subset of patients, and so we must look at this in a very cautious way. But again, this brings up the interaction of diabetes with treatment group assignment. There are a number of caveats in interpretation that we absolutely must keep in mind. The final adjusted statistical significance means predefined significance, but the upper confidence interval for the hazard ratio of the primary endpoint was 0.99. While the relative treatment effect was similar for all the non-fatal components of the primary endpoint, revascularization was the most common outcome event. And 17% of patients withdrew consent, resulting in some missing data. We conclude that study therapy within the safety net provided by TACT appears to be safe. The 10-component disodium EDTA chelation and ascorbate regimen showed some evidence of a potentially important treatment signal in post-MI patients already on evidence-based therapy. However, our findings are unexpected, and additional research will be needed to confirm or refute our results and explore possible mechanisms of therapy. TACT does not, at this time, constitute sufficient evidence to recommend the clinical application of chelation therapy.
Thank you very much, Dr. Lamas.